time maybe for a few questions. Maybe 10 minutes of questions, and then I will give you a short break as we move the live faculty to the endoscopy unit. So I don't know, Haru, Naoisha, Pingo, Chris, you want to come up here, or you'd rather answer from where you are? Any question? Well, if you look at the surgical pylorotomy series, even the surgeons tend to avoid these patients. Like in this series, only 10 to 15%, I believe, were diabetics. They did report 50% or better improvement on those diabetic patients, but I'm sure they were very carefully selected diabetic patients. But this is not our go-to category right now. You may use it as a salvage technique.
Yeah. There's a rapidly evolving interest in pyloromyotomy, and there's going to very clearly be subset patient groups that will benefit from this. You're going to get better emptying of liquids, but not necessarily solids, and so diabetics will be an issue, and it'll get sorted out. The technique is there, but the patient population, as Stavros mentioned, the post-vagotomy-like injuries are right now the ideal group.
Thank you very much, Roman Petrov, Marietta. Hi, I want to thank everybody for an absolutely terrific meeting. If I can ask some maybe guidance, what the length of myotomy for, let's say, type 1 achalasia, type 2, and for non-achalasia motility disorders when you do LAS sparing myotomy, what's the length of that procedure and how much of the LAS you keep? Thank you.
Yes. Thank you very much. Good question. And then type 1 achalasia, of course, so we can focus on to the LES because the proximal part of the esophagus generally dilated already, so food can pass with the gravity very easily. So we can focus only onto the narrow segment. So type 3 achalasia, of course, there is spastic contractions in the esophageal body. So in those cases, we have to put a very long myotomy. So it's no question. Type 1 and type 3 is okay. So discussion is a type 2. Type 2. So pump pressurization of the esophagus. So of course, in those cases, we have to dissect the LES and then how long the proximal extension. That's a question. Still controversial. So myself, at this moment, type 2 patient, we put the standard long myotomy. That is the 14 centimeter or like that. So that means we don't want to repeat the procedure.
My name is Catherine, and I'm a medical resident in New York. And I have a question like, I saw Dr. Zhou present, said 2,000 cases of ESD. In Japan, they have like almost 6,000 cases of ESD. I don't know how like China is supposed to have the most population, and Huashan Hospital is the best hospital in China, and I don't understand how this number like so much bigger in Japan.
Actually, keep touch. Yeah. Well, many cases are problem in Shanghai. All of those cases are referred from all over China. Yeah. And nowadays, we even have patients from Russia, from Egypt, from Australia, even from United States. So every afternoon's work in our endoscopy center, you just cut with the beep of the hybrid error generator. So last year we finished 100,000 endoscopy examination in our endoscopy center. So we have 22 examination room, endoscopy rooms, and more than 30 endoscopists work together in our center.
X.
But I also think you started about a decade after the Japanese, right? Because in Japan it started in 1999. When was the first, in China, I know you are a training center for the rest of China, but ESD probably caught on when? 2008, 2009? So it's probably a decade after Japan, right? That you started doing ESD in China?
So for ESD, we began in the 2006. And for the POM, the first case was finished in the 2010, the August, I still remember. August 16, 2010.
Thank you.
Okay, so if that's it, we are all gonna move to the endoscopy unit. And, hopefully you can ask questions during the cases too, because the cases refer exactly to what the lecture showed. In fact, we can talk about the length of myotomy during the 3 poems. Okay.